Right, everyone, thank you very much for attending our lunchtime workshop. And very pleased to see you here, and I hope that you managed to learn something from what we're about to share with you. So as a quick introduction, my name is Karen Hind. I'm Director of Clinical Affairs at Medimaps Group. Before then, I also have an academic career working in research in osteoporosis as well and methods of DEXA. And I will also give a quick introduction to my colleague, Guillaume, who is an advanced AI data scientist also working in Medimaps and also completing his Ph.D. at University of Lausanne. So without much further ado, we will proceed with the workshop on clinical innovations and advancements for AI for better bone health. So osteoporosis is a global epidemic. Even the situation with osteoporosis has been here for at least 3 decades. We still are dealing with a persistent clinical problem, and many patients are fracturing, and these fractures are bringing pain, and they're bringing a significant personal and financial economic burden to societies around the world. In Europe in particular, we have 4.28 million fractures in 2019. And if we're looking ahead to currently, we have 5.34 million fragility fractures are estimated to occur in 2034. So you can see that the numbers continue to increase despite efforts across the world to really control this burden. A lot of that is due to the aging population as well. We're getting older, we're living longer, which is a great thing, but with that comes a higher risk of bone fragility. We can look in terms of policymakers and healthcare systems. What does this mean to global burdens? Well, in Europe alone, we had a total direct cost of fractures in 2019 at 56.9 billion euros. So it's a huge amount of resource for dealing with fractures and the costs of fractures. If we look at the cost for the patient, there's a 20 to 30% mortality rate within 12 months of sustaining a hip fracture. So we're looking at around 1 in 4 patients who have a hip fracture will die within 12 months of that hip fracture. So a significant burden and worry for the patients themselves. So we talk about osteoporosis being underdiagnosed and undertreated. What do we mean by that? Well, we'll start by looking at anti-osteoporosis therapies. There's been huge advancements over the last 10 years, so we know that these anti-osteoporosis therapies, they work. They reduce fracture risk by 40 to 70%. However, we also know with that anti-osteoporosis therapies are underutilized. They're not getting to the right patient at the right time, and the treatment rates have declined over recent years. If we look closely at that treatment gap, over the last 3 or 4 years, we've had a lot of research into this in terms of epidemiology. And we can confirm that there is a treatment gap of around 70% in Europe. So that means 70% of individuals who actually go on to sustain a fragility fracture have really never even been identified. And these individuals are not receiving the treatment that they need. So that's a huge percentage. And actually, it's an unacceptable percentage. In this day and age, we should not be seeing figures such as this. So what do we do about it? At Medimaps, we are improving the assessment of fracture risk. We will first start with the definition of osteoporosis, which most of you may be aware of. But osteoporosis is a systemic skeletal disease characterized by low bone mass and a microarchitectural deterioration of bone tissue, which then leads to the consequential fracture. So let's look at bone mineral density. So bone mineral density assessment is the traditional approach for assessing risk of osteoporosis and fracture. This is based on DEXA, so dual energy X-ray absorptiometry, and osteoporosis is based on a BMD score, which is -2.5 or lower. That's great. It captures some patients, but it does not capture all patients who will then go on to sustain a fracture. 40 to 50% of osteoporotic fractures actually occur in patients who do not meet the criteria for osteoporosis based on BMD alone. So we're missing around 50 to 60% of patients. If we look in terms of epidemiology again, we can say that yes, BMD is certainly a risk factor. Low BMD is a risk factor for osteoporosis and fracture. And we can see as BMD reduces, then the risk of osteoporosis fractures increases. But actually, if we look at the numbers themselves, more osteopenic women will fracture than osteoporotic. So we'll have more fractures in this osteopenic zone, which is here. And this is creating a problem because if you have a patient who is diagnosed with osteopenia, they are not reaching that treatment threshold, so they're not getting the treatment they need. So the right patient is not receiving the right treatment or at the right time. And these patients then go on to fracture. So let's elevate the standard of care. How can we do that? We can improve fracture risk assessment by applying the full World Health Organization definition of osteoporosis, by looking at not only low bone mass, but also the microarchitectural deterioration of bone tissue. With DEXA, we can achieve both. We can achieve an assessment of BMD, and by including TBS, our Medimaps flagship product, we can include an assessment that relates to bone microarchitecture. Now, trabecular bone score, TBS Insight, has been around for a few years now. It's incredibly validated clinically, and it is a variogram methodology. So it's DEXA-derived, validated, a bone textural assessment based on bone microarchitecture. There are 3 categories of TBS assessment, just as you see with BMD, but the categories we use for TBS are degraded, partially degraded, or normal. And by applying this approach alongside BMD, we can confidently say that we can identify up to 30% more patients who are at risk of fracture who would not have been identified by BMD alone, thereby addressing the osteoporosis treatment gap. So that's 30% more patients who can then receive the treatment that they need. Let's look at the penetration of TBS around the world. And we know around the world from our internal data that we have over 3 million procedures of TBS being conducted. That's great for us because our vision is standard care. Every patient should be having TBS alongside their BMD assessment. So we're reaching over 60 countries. And what we're really proud of here at Medimaps is that our products are always underpinned by the most scientifically robust evidence. And we can confidently say that there's at least 1,000 scientific clinical publications that have validated the use of TBS in clinical practice. And with that, because the evidence is there, we're now establishing over 30 guidelines. Let's look a bit closer at what a difference the TBS can actually make. So on this slide here, you can see we have 2 patients, and they both have a BMD assessment on DEXA. Now you can see that their BMD is very similar, and both of these patients would be diagnosed as osteopenic based on BMD alone. These patients then had a TBS assessment, which is also alongside their BMD, and the patient at the top has a good microarchitecture based on the textural assessment using TBS. The patient at the bottom does not. The patient at the bottom has poor bone microarchitecture. And we can see that illustrated in the heat map, which is what is part of the TBS software. So what does that mean in terms of fracture risk? This patient here at the bottom is at a higher risk of fracture, but this patient would not have been identified based on BMD alone. And what does that mean when we put it all together? So we can apply both the BMD and the TBS status because we have the 3 categories of BMD, we've got the 3 categories of TBS, and we can put it together to really fine-tune the assessment of fracture risk in patients. So the patient at the top who has osteopenic BMD and who has a normal TBS would fall into the category risk of number 4, which you can see on the bone matrix. Sorry. The patient at the bottom has a higher risk of fracture based on their osteopenic BMD, but their degraded bone microarchitecture, and then this patient would fall in the category 6. So this puts this patient at a similar risk of fragility fracture as a patient who has osteoporotic BMD in this category 8 and 7. And this, if you're wondering where the validation of this concept has evolved, the first study was conducted with the Manitoba cohort in Canada, which was based on over 33,000 women and 1,600 major osteoporotic fractures. So with TBS, I already mentioned it can be seamlessly integrated alongside the BMD lumbar spine analysis on your DEXA and easily integrated into the clinical workflow. The resultant report, there's an example here on the screen there. It combines, again, the BMD with the TBS to give that complete assessment of a patient's bone health. So you'll have the option of BMD T-score adjusted for TBS, or if you were predominantly with FRAX, then you can have the FRAX adjusted for TBS as well. So you can see there's a seamless integration there. Okay, so finally, before I pass on to Guillaume, I just want to draw your attention to a really important international position statement that was published in July 2023. And this position statement was the result of significant work by the IOF in ESCEO, who undertook a systematic review of 96 studies published on the clinical validation of TBS, which then resulted in 22 expert statements, which can then guide clinical practice. And we have expert statements in this paper, primary osteoporosis, which confirms that TBS predicts fracture independent of BMD and other clinical risk factors. And then we have a section with expert statements on guiding the clinical use of TBS for secondary osteoporosis management. And then, quite importantly, where we're really making steps forward is the ability of TBS to inform treatment decisions and to monitor patient response to treatment. And the evidence is really accelerating in this field to show that, yes, bone microarchitecture can respond in clinically meaningful ways to certain anti-osteoporosis therapies, particularly those which have an anabolic action. So thank you for your attention. I'm very aware of time, so I will now pass over to Guillaume, and he will talk about the clinical applications of AI.
Thank you, Karen. It's good to have you here. Thank you for attending this workshop. We will move on to how to transform the osteoporosis assessment and management with artificial intelligence. And we will include this into the patient journey. So first, let's have a quick step back and see what are the different tasks of AI related to osteoporosis management and assessment. We have here two comprehensive reviews that covered the time frame from 2014 to 2023. And what these reviews highlight here is that you have different types of tasks of AI applications in osteoporosis assessment. On the left here, we can see that the major applications of AI are osteoporosis classification tasks and fracture detection tasks. But we also have bone properties assessment to, for example, assess the bone mineral density from other than DEXA imaging devices. We also have risk prediction tasks to predict the fall, to predict the survival status, for example, after sustaining a major osteoporotic fracture. On the right, in the middle, we can see that there are different types of input that can be used to better predict outcomes. For example, AI applications might benefit from databases that include clinical risk factors or already acquired bone health parameters to predict undesired outcomes. And we have also AI applications that rely on image analysis. For example, CT, computed tomography, X-ray, quantitative ultrasound, MRI, or DEXA. And on the right chart, we can see that there is an exponential trend in research involving AI in the osteoporosis field, with a continuous growth in published articles. Okay, so now let's have a broader view of the patient journey along the TBS Insight ecosystem. We have different streams here, and from left to right, we have the traditional approach, which is the reactive one. We have osteoporosis disposition. Let's say we are postmenopausal women. We already have prevalent fractures, so we will go to our referring physicians that would indicate having a DEXA. This is where we have the TBS Insight Osteo to assess the trabecular bone score as a complementary analysis of the bone mineral density to further diagnose osteoporosis, and then we may have some patient applications to empower the patient to better follow up and monitor the outcomes. And now a more advanced approach, which is more proactive, consists of identifying patients with other indications of osteoporosis. For example, patients who sustained a fracture or a patient having a back pain. That might go to the emergency department, get an X-ray, get a CT. And this is where we have opportunistic screening models that enable to opportunistically identify patients with an elevated risk of bone fragility. This is the TBS Insight application, which I will present to you a bit later. And basically what TBS Insight ASXR performs, it performs a patient triage based on their estimated bone fragility risk. For those having an elevated risk, would be directly referred to physicians to have a proper bone mineral density and TBS assessment to have the complete view of their actual bone health. And we also have orthopedics applications, meaning that patients with an elevated fracture risk or fragility risk would benefit from trabecular bone score texture analysis to better determine what would be the outcomes after sustaining an intervention. Okay, so now let's have a closer look in this TBS Insight ASXR model, which enables to predict the bone fragility risk from conventional X-ray. What is the concept of the ASXR model? First, it's a bone fragility case finding, secondary fracture prevention, and primary fracture prevention. The idea here is to support early detection and intervention so that the patient might benefit from the optimum care at the right time. And how do we qualify the bone fragility? Well, it's characterized by both a degraded TBS and a low bone mineral density. And the idea here is to refer the very high fragility risk individuals for a full bone health assessment by DEXA. Here we can see the class number 9, which combines both the BMD density status as osteoporosis and a degraded textural status. So what is the current concept and how TBS ASXR works? Well, we have a multi-stage deep learning application where we have a first stage consists of the automatic vertebral identification and segmentation. So our model performs a triage based on the DICOM acquired X-ray scans, and as long as there are at least 2 vertebrae that are identified on an X-ray, the ASXR can perform a fragility risk assessment. So the second stage consists of a convolutional neural network analysis to predict and determine what would be the bone mineral status, bone mineral density status, and the bone microarchitecture status based on these vertebrae. And we have on this convolutional neural network analysis a fusion model that also includes patient characteristics such as the age, the sex, and we also have textural features that better reinforce the prediction of the fragility risk. Now here is an example of the first version of the ASXR model. So we have both the bone mineral density estimation and the bone microarchitecture estimation as an output of our model. So here we could see that the patient has been predicted being osteoporotic with a confidence interval falling into this osteoporosis class. And we also have from the textural analysis, the microarchitecture estimation being here degraded. And the overall bone fragility index would indicate a very high risk of fragility. So this comprehensive report enabled to refer patients to have proper DEXA examination for confirmed diagnosis. Now, we may wonder, how does the future look? Is it scary? Is it exciting to have AI in the different workflow? Well, the question is not if, but when and how. We are currently externally validating the ASXR analysis, and this is very, very exciting. So now I think it's time. We have more minutes for questions. And if you want more details on this ASXR model, there will be a dedicated session on Sunday from 9:30 to 11, where we'll be giving an oral presentation. We will go more in details about how the model was trained, how was it validated, and externally assessed on its performance. Thank you very much.
Yes. First of all, congratulations for your presentation. The question is related to the fact that I'm interested in know if, in addition to the spine, the hip can be another area under investigation, because, as you know, the hip is one of the first anatomical site where the osteoporotic fracture occur. So how is the status of the hip?
Absolutely. That's very interesting. What we did want to have as a very first version of the ASXR is the lumbar spine, just by the reason that the ground truth, the bone fragility risk, is derived from the TBS and the BMD. TBS being validated at the moment at the spine, this is the very first version. But now in clinical practice, what determines the osteoporotic status, it's the minimum T-score, BMD T-score of different anatomical sites, being the radius, the spine, and the hip. So the very next stage of ASXR will be to extend to other anatomical sites, accounting as a ground truth not only the spine bone mineral density status and the trabecular bone score, but the minimum T-score, so that whatever the anatomical sites of the X-ray, we would associate it with the estimated minimum T-score. So in the next stages, we will of course evaluate the performance. We are already training some models in-house, and we will present on the Sunday session the external validation of the spine-only ASXR. But that will definitely come next.
And just to add to that, so with your TBS flagship product, you will be able to adjust the femoral neck and the total hip BMD T-score as well. So if you want to incorporate that BMD at that particular site, you can combine that with the TBS. Thank you very much for attending and for listening. If you have any questions at a later date, then feel free to contact me at Medimaps. Very happy to converse later. Thank you for your attention. Thank you.
Thank you, everyone.